Yeah. Good afternoon. My name is Diana Echenique, and on behalf of the Office of Minority Health Research Center, we welcome all participants in observance of the National Hepatitis Awareness Month. We are pleased to bring this webinar, Going the Extra Mile to Eliminate Hepatitis C in the Hispanic Latino Communities. The webinar is a collaboration between the Office of Minority Health Research Center, the Valley AIDS Council, and the Westbrook Clinic. I would like to say a few words about the Valley AIDS Council. This is the primary provider of HIV prevention, education, and testing services, and the only Ryan White funded agency providing medical care and supportive services for people living with HIV in the 15-county area that stretches from the lower Rio Grande Valley on the U.S.-Mexico border and up along the Texas Gulf Coast to Corpus Christi. The VAC is also the organizer of the 2017 National Latino HIV Hepatitis C Conference, May 22nd to the 24th in South Padre Island, Texas. With this, I also would like to say a few words about the Office of Minority Health Research Center, which is bringing you today this webinar. The Research Center was established by the Office of Minority Health in 1987 as it was deemed necessary for the agency to develop an entity as a point of contact for health professionals and others regarding information on minority health topics. The Research Center is a one-stop shop for information on minority health literature, statistics, documented research, and referrals to other agencies and entities. Our research center includes a communications team, a website, a knowledge center, information services, and capacity building team, which I will be providing you further information on what those teams and how those teams can, what they do and how they can serve you, the audience. Now, going the extra mile to eliminate hepatitis C in the Hispanic Latino communities. You can see we have 4 objectives for today's webinar. And before I can introduce our speaker, I would like to, for you all to participate on a poll question. Maria? Thank you. Please answer the question and we will provide the answers shortly. We will provide about 20 seconds before we close the poll. Okay, and here are the answers. The correct answer is 50% reduction in HIV and HCV, viral hepatitis C incidence, and 10% reduction in HCV related to mortality. And the question was, of course, you can see listed, what are the current global strategies for reduction in HCV incidence and HCV-related mortality? With this, I would like to present our today's speaker, Dr. Allen. He is a clinical associate professor of medicine at the Texas A&M University, where he is currently a principal investigator for various phase 2 to phase 4 clinical drug trials. He is also the founder and medical director of the Austin Hepatitis Center and HepCare, a specialty pharmacy. He received his medical degree from the University of Dundee in Scotland. He completed his residency at Heinemann University Hospital in Pennsylvania and is and he's a gastroenterology and hepatology fellowship at the University of California. While in San Francisco, Dr. Alan was an NIH research fellow in chronic liver diseases. He's board certified in internal medicine and gastroenterology. He has written and published numerous articles for peer-reviewed journals in the topic of chronic hepatitis C and chronic liver disease. Dr. Alan, we are honored to have you with us today.
Thank you. Good afternoon, everybody. I'd like to welcome to the webinar relating to how we best eliminate hepatitis C in our Hispanic and Latino communities. Next slide, please. So this slide summarizes what the question was at the start of this presentation. This is the World Health Organization recommendations in terms of global hepatitis C strategy from 2016 to 2030. This strategy was implemented last year and was further supported earlier this year. And the strategy globally is by 2020, it is the expectation that we will have a 50% reduction in HCV incidence and 10% reduction in hepatitis C-related mortality. In addition to that, the WHO are recommending by 2030 we have a 70% reduction in hepatitis C incidence and 60% reduction in hepatitis C-related mortality. They're recommending that strategy is calling for major increase in diagnosis of chronic hepatitis C infection and treatment coverage of eligible persons by 2030. So move forward with these recommendations, these strategies. To achieve these strategies, we must first understand who is getting hepatitis C currently, how do we link patients to care, and ultimately how do we get them onto therapy to get them on the path to being cured of hepatitis C. Next slide. Given these strategies, there are clearly a number of barriers to achieving hepatitis C cure. And this slide summarizes some of the barriers from HCV infection to diagnosis, to referral to a specialist, and finally initiating therapy. And you can see there are frequent barriers. The words in yellow indicate, I think, specific areas, especially in our Latino and Hispanic communities, in terms of awareness of the infection, lack of medical coverage, and failure of the primary care physician to actually screen for the hepatitis C infection. There's also limited availability of specialists. There's fair understanding of what hepatitis C is. There's clear stigmatization of being infected with hepatitis C, especially in our in the young kids who are taking IV heroin or sharing needles through heroin use. And we'll talk a little bit more about substance abuse and hepatitis C and some of the new CDC data that came out last week. And finally, of course, one of the biggest issues in healthcare with the Hispanic and Latino community is communication difficulties with their providers. Next slide, please. So this is a bar graph looking at population studies showing the significant gap in hepatitis C care in the United States. And this is looking at the cascade of care over a 10-year period from 2003 and 2013. 2013 was the advent of the newest medications called direct-acting antiviral agents. That was the beginning of the newest drug. So currently, we believe there are about 3.5 million infected with hepatitis C, but yet only 50% of patients have been diagnosed or aware of the infection. Of those patients who know they have infection, only 43% have been accessing health care. So 60% of patients have not been linked to care. Of the 40 or so patients who have accessed care, 16% have been prescribed treatment, and approximately 9% have achieved a cure. So essentially what this graph is showing you that approximately 90% of patients do not know they have it, have not been linked to care, and have not been able to access treatment. So this is a significant burden in all communities, especially, as I'm going to show you more data, with the Hispanic and Latino communities. Next slide, please. This is a very important study called the NIH Study that looked at chronic diseases in the U.S. And this data specifically looks at the issue of hepatitis C. NIH estimates, as previously stated, there are about 3.2 million people with hepatitis C in the U.S. However, if you really look at the data, HCV cases not included in NIH are an additional possibly from 1.9 to 3.8 million people. And these are patients who are homeless, incarcerated, veterans or active military or healthcare workers. There may also be patients who are on chronic hemodialysis or hemophiliacs. So really, the estimate of total HCV cases can be on the conservative side about 5.2 million to the upper limit of estimation of 6 million people. If you put that into perspective, the number one country with the most number of hepatitis C cases in the world is China at approximately 20 million. Pakistan at number 2 at 15 million. India at number 3 between 10 and 15 million. So we're not in that arena, but clearly we have a long way to go in getting more patients screened and getting them access to care. Next slide, please. This study, this NIH data looks at prevalence of cirrhosis and advanced fibrosis among those who have chronic hepatitis C, and they compared between 1988 to 94 and 1999 to 2012. So it is estimated that there are about just over 370,000 Americans with cirrhosis and almost 350,000 with advanced fibrosis, and nearly 1 in 5 adults with hepatitis C infection have cirrhosis. During 2007 and 2012, cirrhosis was associated with increasing age, diabetes, and obesity. And if you look at the bar graph, you can see at different time periods the significant increase in number of patients with hepatitis C and cirrhosis, with up to 17% now between 2007 and 2012 with cirrhosis and with 16% with advanced fibrosis. What this data is showing you is that if you allow the virus to continue to infect the liver and continue to harm the liver, you'll have progression to cirrhosis and the subsequent complications such as liver failure, liver cancer. So it is imperative that we screen patients now and treat early than waiting for advanced disease. Next slide, please.
And now we're going to have our second poll question. Maria? Please take about 20 seconds, answer the question, and we will close it and show you the answer. We can begin seeing our answers. And Dr. Allen will address the response. And this is expected that 37% of the respondents chose Mexicans, but the correct answer actually is Puerto Ricans. And now Dr. Allen will explain where the data comes from and how we got to that point.
Thank you. Next slide, please. So earlier on, we talked about the NIH data. So now there is this NIH sub-study in looking at the Hispanic and Latino population. And this is an important study called the HCH-SOLVE study. This was published in Journal of Infectious Disease on January 2014, looking at Hispanic community health study and study of Latinos. They looked at almost 6,500 adults in 4 communities, the Bronx, Miami, Chicago, and San Diego. And what the data showed was that the HCV epidemic among the U.S. Hispanics and Latinos was heterogeneous. And when they looked at HCV antibody prevalence, in the original NIH study between 2000 and 2010, the prevalence nationwide is 1.5%. However, in the 4 communities that they reviewed, in the Latino and Hispanic population, it was 2.0%. But really, if you further hone down in the data and look at different populations of Hispanic Latinos, what you see is a diversity in terms of prevalence. And in fact, the highest, as previously stated, is the Puerto Ricans at 11%, and particularly female Puerto Ricans at 3.9%. Mexicans prevalence was 1.9%, Dominicans 1.5%, Central Americans 1%, South Americans 0.4%, and the lowest ones were Cubans at 0.8%. So really what this data is trying to, what it explains to us is that the specific Hispanic Latino groups may benefit from increased levels of HCV testing and treatment based upon the groups itself. So greater awareness or more aggressive testing needs to be done in areas of higher prevalence, such as the female Puerto Ricans, as compared to, say, Cubans. So hopefully this data will help you determine how you can strategize within your own communities what is the best way and who should be targeted, especially if you have limited resources. Next slide, please. This is another important study, and this is looking at hepatitis C awareness in the Hispanic Latino population. And some of this data suggests specific lack of awareness of hepatitis C virus. This is a study published in 2015 called the UCI and the Latino Network Study, and they looked at 7 disease states ranked in terms of awareness among Hispanics. Number 1 was diabetes, number 2 was breast cancer, number 3 heart failure, and then hepatitis C was number 4, liver cancer number 5. And what it shows is that 91% of Hispanics have some awareness of hepatitis C. The Hispanics were 3 times more likely to be completely unaware than non-Hispanic whites. Additionally, 16% of Hispanics, can you go back to the previous slide, please? Thank you. Know that, that there is no vaccine for it as compared to 25% of non-Hispanic whites. And then finally, 18% of Hispanics first heard about hepatitis C from their doctors compared to just 9% among the non-Hispanic whites. Next slide, please. What this looks at further is the NIH data, awareness of hepatitis C status by risk group in infected HCV adults. This study ranging from 2003 to 2012. And the question was, were you previously aware of your hepatitis C status prior to NIH HCV testing results? And if you look at the exposure group, okay, the overall HCV population percentage is 59% awareness. But in those who are in the birth cohort, i.e. if you're born between 1945 and 65, there was a little bit higher awareness of hepatitis C as compared to the PWIC population. These are persons who inject intravenous drug, was 56%. If you look at, in terms of race, Hispanics actually were more aware of the hepatitis C status than, say, the African American population. And if you look at, in terms of poverty level, clearly there's a big gap. In those who are 2 times above the federal poverty level, they have much greater awareness, 72%, compared to those who are at a lower poverty level at only 48%. Next slide, please. So this study looked at the multimedia prevention program in poor Hispanics who are co-infected with HIV, who are infected with HIV, injecting drug users over 6 months after intervention. So they provided computer-based intervention of increasing awareness about hepatitis C. And they looked at 6 months later if this computer awareness improved their awareness. So this was published in the Journal of Healthcare for the Poor and Underserved in 2013. There were 138 participants, and about 64% completed 6-month evaluation. About 40% were active IV drug users during the 6 months prior to the study enrollment. And what the study showed was that using the 6 months of evaluation about hepatitis C, increasing awareness about hepatitis C, there was a significant decrease in HCV risk behavior, especially decreased use of shooting galleries and paraphernalia. There was increased knowledge about the clinical manifestations of hepatitis C and treatment. and about HIV co-infection. There was also increased knowledge about HCV infection and social risk behaviors, such as sharing razor, unprotected sex, and so on. There was also reduced misconceptions that hepatitis C is not transmitted through coughing, sneezing, sharing food, or cooking utensils. If you start with low awareness, if you can provide education to this population, the data clearly shows that there is value in educating and providing that awareness. Next slide. So in terms of screening, who should we screen for hepatitis C? You can divide into two buckets. So-called birth cohort testing, which is persons born between 1945 and 65, which is standard of care and recommended that all primary care physicians do that, and that is paid by the new healthcare law. But also risk-based testing, and predominantly in those who have past or current injection drug use. Next slide. If you look at those who are infected with hepatitis C, that's 3.5 million people. About 60% are current or former persons who injected drugs, the PWIDs. And if you look at new cases of hepatitis C, in 2013, there were 20,000 new cases of hepatitis C, of which 80% were IV drug users. Last year, there were 35,000 cases, of which 85% were drug users. Next slide, please. Four days ago, the CDC put forward new data in terms of hepatitis C infections are soaring in the country, and is fueled by prescription painkiller abuse. The CDC on May 11th released this data. From 2006 and 2012, acute HCV infections were tripled in those who are less than 30 years old. Specifically in 4 states, Kentucky, Tennessee, Virginia, and West Virginia. New cases of HCV increased from 1.25 per 100,000 cases in 2006 to 4 per 100,000 in 2015. And in states such as Kentucky in 2013, there were 5 cases. 13 Delaware and South Carolina, no reported cases. And this tracks first-time heroin use. So in 2006, there were 90,000 folks using heroin in our country. Now we're up to 156,000 up to 2012. So increasing drug use, increasing painkiller abuse, is tracking increased infection of hepatitis C. And this is what I consider to be the second wave of hepatitis C in our young population, those who are aged between 19 and 20, which is going to hit our medical system. Next slide, please. Let's look at now the issue of linkage to care and the missed opportunities in a primary care setting. This is a study looking at hepatitis C antibody tests and visits to a primary clinic between 2005 and 2010, of which there were 566 patients. Of these, 458 patients underwent HCV RNA testing. And what they found was that 308 were RNA positive. Okay? Of that, 38% received specialist care. Just under 7% were treated, and just under 3% achieved cure. So you can see it's substantial gaps again in linkage to care and achieving cure. Next slide, please. Now let's look at this cascade of care in the perspective of the PWID population. We've already discussed that this is a second wave of hepatitis C infection in our younger population. And now let's look at the care that we provide to them. So the current data as on the slide is looking at the cascade of care of overall population. Now next slide, please. If you look at the PWID population, it's even more have been treated. We need to do a better job in this unique population, especially the stigma that occurs with having a history of drug use in the past. Next slide, please. This is the CDC data looking at a trial called the HEP-TLC initiative between 2012 and 2014. And what their goal was identification of hepatitis C and linkage to care. The blue dot is what the goals were. And this is conducted at 206 venues in the U.S., HCV testing in community health centers, and settings that provide service to the PWID population. And so about 7,580 folks had HCV antibody positivity. 63% received HCV RNA testing, and 72% of those who got tested were positive. 81% received their test results, were told what they had. 76% were referred to primary care and specialty care, and that was achieving their goal. Okay, but 44% attended a medical appointment. So you can see there still remains a 60% gap of linkage to care. So the issue is, how do we improve a linkage to care? What strategies should we use to improve that linkage to care? Next slide, please. So there are certainly barriers to linkage to care, and this slide indicates those barriers, such as fragmentation of HCV services, lack of understanding about the importance of care, and all the way down to stigma of having an infection. Next slide. For the Hispanic and Latino population, there may be some very important issues as well, such as language and cultural differences, medical and provider bias, socioeconomic factors, such as lack of medical insurance, increased use of alcohol, and increased IV drug use of the Mexican Americans and Puerto Ricans. They tend to inject more frequently, share more paraphernalia, and disinfect less often with bleach, which enhances the infection. Next slide. So one of the models that we've tried to use and we've instituted nationwide from my office is this called Linkage to C Care. The website is linkagetocare.com. This is a hub and spoke model which centralizes multi-site communication. What we have been undertaking over the last several months is going into treatment centers, sober living homes, or where folks with history of drug use are undergoing withdrawal from their drugs or undergoing treatment for their addiction. We test them, and if they test positive for hepatitis C, then we, either the site itself or the individual patient, gets data put into a web-based platform, which is HIPAA compliant, which is the Linkage to Care platform. And there are Linkage to Care specialists that communicate with the patient and then find a site or clinic geographically located close to them and make sure they get an appointment and make sure they get into the appointment and make sure they stay in the appointment and make sure they get on treatment and make sure they complete their therapy. And this hopefully fill those gaps of the linkage to care, that 60%, and then access to the treatment as well gap. Next slide, please. Now, the good news, despite all these issues, is we have amazing medications now providing cure for hepatitis C. In 1991, just at the time the virus was first detected, we were looking at less than 10% chance of being cured. Now, with the advent of the new medications called direct-acting antiviral agents, DE agents, we're looking at between 90 to 100% chance of being cured with the simplest treatment of taking one pill a day, as short as between 8 and 12 weeks of therapy for the majority of patients. Next slide, please. The value of a cure is not only eradicating the virus, but also data shows that we can reverse or show regression of fibrosis and cirrhosis. This is a study looking at achieving cure and then monitoring their fibrosis and cirrhosis using a technology called a FibroScan, which is like an ultrasound. And basically, it's a retrospective chart review of patients who had F3, F4 baseline at the prior to starting therapy, and then they were cured. There were 100 patients, and they were given sofosbuvir-based therapy, oral therapy. Overall median time for improvement for cirrhosis was 2.5 years, and for versus those who had, cirrhosis 3 years compared to those who had F3 fibrosis, 2.5 years. And you look at the bar chart that in patients overall, improvement of fibrosis occurred in 60% within the 2 to 3 year duration. In patients with cirrhosis was 55% over the 2 to 3 years. Next slide, please. Additionally, achieving a cure shows that there is a reduction in all-cause mortality, liver-related mortality or the need for a transplant, reduction in progressing to liver cancer, and reduction in going to liver failure. And what it shows that baseline factors significantly associated with all-cause mortality in patients with hepatitis C were those who were older, those who were infected with genotype 3, those who had a higher fibrosis at the time of the treatment, those who have a history of diabetes, and who, of course, use large amount of alcohol, more than 20 to 30 grams of alcohol per day. But clearly, achieving a cure shows improvement in not only regression of fibrosis, but other complications of the liver disease. Next slide. In terms of therapeutic use in 2017, all therapies are now oral therapies. And for the first time, June of 2016, we have our first therapy, which is a pan-genotypic drug. This means that it works in all the genotypes, so 1 to 6, and this drug is called sofosbuvir and valproatovir. This is a single formulation, 1 pill a day for 12 weeks for everybody, for all genotypes. Next slide, please. Now, over the next few months, in August of this year, there are going to be new medications coming out, 2 new medications, which are also going to be pan-genotypic, in which the duration of therapy may be reduced to 8 weeks for those who are naive to treatment. And in patients who failed previous therapy for these drugs, there's going to be a new drug as a salvage therapy. So you can see we are certainly advancing in the right direction and giving more therapeutic options. The problem is getting access to these medications through barriers such as insurance company approval. Next slide, please. And one of these barriers is Medicaid. This slide looks at restrictions Medicaid has put in place nationwide in who can get access to these therapies. And the dark blue to black is that if you have to have the highest degree of fibrosis, so-called F3 and F4, before your Medicaid will approve therapy. So if you have no fibrosis or minimal or moderate fibrosis, Medicaid would not approve the therapy. So you're restricting a large population that could get treated and cured, but because you don't have advanced fibrosis, you're not going to get this therapy. And this, unfortunately, afflicts the PWIT population most, because these are young kids who have been recently infected, and they're not going to have as much advanced fibrosis. So they're going around infecting other members of the community. So this is a short-sightedness of Medicaid. If they opened access to everybody, we could potentially reduce the disease burden in the community and essentially provide a form of vaccination, so-called herd immunity, to the community. Next slide. Now, we want to try and we have access to a lot of therapy, advanced therapy. We need to overcome, of course, the restrictions and access to treatment. But we also need to expand HCV care. These are some examples where we can expand HCV care, especially in the primary care arena, community health centers, tertiary care clinics, focusing on drug and alcohol clinics, prisons. We can also expand by using telemedicine, and then community-based campaigns in the Latino population. Next slide, please. Now, this study looks at HCV disease burden in the United States, and increasing HCV treatment capacity is essential. So in 2015, HCV disease burden resulted in just under 200,000 with decompensated cirrhosis, 154,000 with liver cancer, and just under 350,000 liver-related deaths, and need for transplant 31,000 patients. But if you change the capacity to achieve the World Health Organization goals, you can have an impact. But the capacity that you have to increase is substantial. The bar graph on the right-hand side of the slide shows currently we're treating 280,000, and this is 2015 data. We have gone down by 25% since then. Not gone up, but gone down. We need to increase by 2030 400,000 patients being treated. By doing that, we reduce progression to decompensated cirrhosis, liver cancer, liver-related mortality, and need for transplant. So you can see how important it is to increase screening and linkage to care to achieve that 400,000 capacity and goal to achieve the World Health Organization's recommendations. Next slide, please. So let's look at some clinical scenarios or clinical centers that are trying to achieve this increased capacity. One of the biggest one is the VA National Healthcare System. The veterans in VA care currently in 2013 are 5.7 million, and about 3% were diagnosed with hepatitis C, but yet about 45,000 remain undiagnosed, that they potentially have hepatitis C, but we've lost contact with these folks. Approximately 50% of all hepatitis C cures since 1999 in the VA was achieved in 2015. The reason for that is because the government put the resources in at that time to increase linkage to care and treatment of hepatitis C patients in the VA system. In fact, from 2010 to 2015, over a 5-year period, there was an 8.5-fold increase in number of people treated. There was a 21-fold increase in the number of patients being cured, and a 2.5-fold increase in therapies achieving SVR. In fact, if you look at the data on the right-hand side of the slide, at the bottom, achieving SVR rates in 2010 was 36%. In 2015, we're over 90% cure rates with the new therapies that we have. The VA has done a tremendous job by putting resources in, increasing screening, and then access to new therapy, and that's how you can make a difference. Next slide, please. How about the primary care arena? So in the U.S. population, about 2.2% are infected. The average patient load for a primary care clinician is about $2,000 per year. So if you do a calculation, it is expected that 40 patients per year will be present in the primary care clinic system. Next slide, please. In terms of primary care perspectives on hepatitis C management and screening, there are a number of barriers. This study looks at what primary care physicians feel about hepatitis C screening and some of the barriers to screening and reasons not screened. The number one reason for barrier screening, 96% said, was time constraint. They just didn't feel they had enough time. 71% were not sure if the patient actually were previously screened. 57% said there was lack of resources or logistic support. 36% said that the remain current with guidelines means that they didn't understand the guidelines, what the recommendations are for age cohort testing or risk-based testing. And 32% said insurance coverage concern. They didn't know that insurance would pay for the test. In terms of reasons not screened, 37% thought patient was not a treatment candidate. They decided that beforehand the patient should not get therapy before even deciding to screen. Next slide, please. So can primary care doctors treat hepatitis C? Can they provide the same level of care for hepatitis C patients? There are two studies, one that were published looking at this issue. The first one was hepatitis C treatment by primary care providers. This is a retrospective analysis between 2012 and 2015, academic and specialty sites, of which there were 6. And this model trains primary care physicians to present cases, to treat cases, and they're presented to specialists, and they make recommendations of how best to treat. These are states, Arizona, New Mexico, Oklahoma, Texas, and Utah, and Washington. The therapies were the new DA agents, and what the data showed clearly that those who were in the clinic system, the primary care doctors, compared to the specialists, in terms of intention to treat analysis across types 1 to 3, the outcomes were exactly the same. The cure rates were exactly the same. So there was no difference in primary care doctors treating and specialists treating. Next slide, please. This is another study called the Ascent trial, looking at the primary care providers in 2015. This is a multi-center open-label phase 4 study of 600 hepatitis C patients in the Washington, D.C. area, 3 community healthcare systems. The providers were given 3 opinions on the most recent guidelines, and they all prescribed the most recent therapy called litifiravir and sofosbuvir. And what the data clearly shows in the bar graph on the right-hand side, that the cure rate overall was 94%, but were actually higher in PCPs and nurse practitioners compared to the specialists. The specialists saw more severe cases, but you can see the outcomes were excellent in the primary care arena, which further gives you evidence that primary care physicians under the right circumstances can treat hepatitis C patients. Next slide, please. So in summary, eradicating hepatitis C is everyone's job in the community. There are 3 parts to hepatitis C: awareness, treatment, cure. We need to first find the undiagnosed hepatitis C using hepatitis C rapid testing. We need to look at particularly this new next wave of hep C infection, so-called the PWID population, and continue to do age cohort testing in those who are born between 1945 and 1965. We must do a better job in preventing infection and reinfection, especially in our PWID population, in terms of outreach and education in our Hispanic Latino population, and it works, as previously stated. Use safer injection counseling. Reduce reinfection counseling, especially instituting needle exchange systems. The CDC data that was published 4 days ago also showed that those areas that had needle exchange system had significant reduction in reinfection compared to those areas that did not have needle exchange system. And finally, providing access and delivery using our Linkage to Care program, accessing hepatitis C drugs, focusing on increased capacity by increasing primary care-based therapy, looking at methadone-based directly observed therapy. We're about to launch a new project in treating within methadone clinics. So when they get the methadone, they take the hepatitis C drug at the same time. How about accessing specialty care through telemedicine? So geographically, if you're living in a rural community, you don't have access to a hepatologist or gastroenterologist, you don't have to travel long distance, but you can simply encounter the care through essentially Skyping through telemedicine. So there are different ways that communities can enhance eradicating hepatitis C, and it requires all partners to work together in synchrony. I'm going to end the presentation here, and we will continue for the remaining part of the presentation.
Thank you, Dr. Allen. And I know that as we know at the beginning of the webinar, that you are the founder of the Austin Hepatitis Center and the Hep Care Specialty Pharmacy. Could you please tell us a little bit of the work that you do there and how you collaborate with the rest of the community in Texas?
Thank you. Thank you. That's a great question. So the Austin Hepatitis Center itself is a private center, and our goal and focus has always been increasing community awareness and partnership with the community. We've also developed, in partnership with a community center in Austin, we received a grant from the federal government to actually develop a hepatitis C clinic for uninsured and Medicaid populations through community health centers. So we work there as well. Through our Linkage to Care project, we received a grant from Gilead in supporting screening and linkage to care patients who are in the PWID population, who are under harm reduction or getting off drugs. And this is a statewide program we can work with all treatment centers throughout the state. And in a few months, we're about to launch a new program in conjunction with the Texas Health Department. They have 22 methadone-run facilities, methadone clinics, and we're going to be developing a program where we will train the doctors at the methadone clinics to treat hepatitis C within their own system and work in conjunction with us so they treat locally rather than referring to a specialist where they may not have access geographically. So our goal has always been to partner with the different community systems within our own city and also state and work best with different populations, those including insured, non-insured. And we also provide telemedicine program for our hepatitis C patients as well, so they don't have to travel long distance to us. Thank you.
Thank you very much for that explanation. Also, you mentioned during your presentation, and this is a question has been posted, can you tell us a little bit about linkage to care?
Sure. The website is called linkagetocare.com. And so what this website tries to do is to fill that gap of that 60%. So when the patient gets tested for hepatitis C, either themselves individually or we're focusing a lot of the treatment centers, the methadone clinics, if they test positive, the case manager, the recovery coaches, or the patient themselves can register themselves into the website. It's all HIPAA compliant. And once they're registered, they're connected with a navigator. The navigator connects with the patient, talks to the patient through either email or directly by phone, and then educates them about hepatitis C, the need to get further care, need to get cured, and then makes an appointment for them for a physician or provider that's close nearby them. If we cannot find somebody that's close nearby them, or if they have, say, they're uninsured and there's no community clinic, then we provide free care for them through our telemedicine program. And then once they get to the provider, we try and get the drug approved through our HepCare specialty pharmacy, and we take all the burden of getting the drug approved. We'll fight with the insurance company and whatever is necessary. Sometimes we've even sued Medicaid to get the drug approved. And once the drug approved, then it goes to the facility, the clinic, and then the patient gets initiated in therapy and puts on therapy. Throughout this process, their navigator continues to connect with them and make sure they finish their full course of therapy and get cured. Now, in the PWID population, the biggest concern is that they're cured, but they're not immune. So if they went back to taking drugs again, they can potentially get reinfected. So in that population, we continue to provide education to them, the need to not to relapse to taking drugs again. And if they did go back taking drugs, we try and inform them to go and get tested then again. Those who don't take drugs, those who are cured, do not need to be tested again once they've been cured. If you belong to the high-risk group, such as those who are taking drugs again, you need to be retested annually to make sure you're not reinfected.
Thank you for that intervention. Another question that was posted is, should we test participants from Asia? And I would like to add to the answer that this webinar is, in the presentation, the content is all in relation to the Hispanic Latino population in the U.S. But Dr. Alam, would you kindly add further to the answer?
So in terms of the Asian population, the risk for hepatitis C, as it's in China, is very high. So currently the CDC U.S. Prevention Task Force is recommending screening based upon age cohort testing. So regardless of what race or culture or where you come from, if you belong in the age group between 45 and 65, 9 to 45, 9 to 65, you need to be screened. And then, of course, it's a risk-based testing, especially if past or current use of drugs. The Asia population specifically relates more to the hepatitis B population. So hepatitis B screening. So if you are born in Asia, or if you are born here, but your parents were born in Asia, then you need to be tested for hepatitis B. Additionally, recently, the new treatment for hepatitis C received a black box warning. It was based upon recent evidence that suggests that if you had hepatitis C and you received hepatitis C therapy, you were never screened for hepatitis B in the past, but you had the infection, you didn't know you had the infection, you can reactivate the hepatitis B infection and go into liver failure. So every hepatitis C patient automatically needs to be screened for hepatitis B to make sure they don't have hepatitis B as well, just as they need to be screened for HIV. So if they have HIV and hepatitis B, they need to be treated for those infections first before you treat the hepatitis C. I hope that answers the question.
Thank you. Yes. And while the public can provide us more with more questions, I have one more, and then I'm going to present a little bit on what resources we have available at the research center here. But prior to that, I would like to post another question, Dr. Alam. What legislative efforts are being done to help with getting the medications to inmates currently incarcerated?
That's a great question. So in terms of incarcerated folks, less than 1% are being treated. If you treated every Hep C patient incarcerated, it would cost about $1.3 billion. The annual healthcare cost for incarcerated is about $1.2 billion. It would be overwhelming. So what they're simply doing is not allowing access to care unless you have certain specific criteria, number of years that you're going to be in it, the degree of damage to the liver. So essentially what's happening is that these folks are being discharged or let go once they've finished their time in prison. And they're actually using our Linkage to Care program, so they get put information to our Linkage to Care program, and then we find a provider for them. If they don't get put into the program, whatever the area of the state they're in or country they're in, they're typically given 30 days of a clinic card to go out and connect with their healthcare provider. And hopefully that healthcare provider can put them on the path. But at this moment in time, in terms of active treatment within the prison system, no. Very little is being provided. And that is one of the issues that we're still trying to combat at the moment.
Yes, and to that is these programs, preventive programs in management of treatment of diseases are for incarcerated populations are managed at the state level. So while at the national level from CDC and any of the other health institutions, we cannot be mandated how the services are provided to incarcerated populations. It's still at that level they're trying to drive policies that will engage states at the state level policies to provide adequate services to these populations. With that, we don't have further questions from the public, but if I receive more questions, and as we have a few more minutes, I will present them shortly. But in the meantime, for the last remaining minutes, Maria, could you kindly advance the slides? Yes. I said at the beginning that there are a few resources that we would like to offer to the public at the research center, and that is under the website of OMH, Office of Minority Health. We at the research center manage the social media platforms. Our communications team also manage the several campaigns that are posted there on this webpage. The IT team maintains the webpage also, and you can direct questions and request the information to us. Could you advance the next slide, please? We have the capacity building team, which can offer technical assistance and capacity building services to state and local health departments, minority serving healthcare agencies and nonprofit organizations throughout the United States and its territories and jurisdictions. We provide technical assistance in different areas, as you can see. Next slide, please. The Knowledge Center that we have is a key aspect of the research center here, which collect and compile and disseminate minority health information. Currently, we have over 56,000 documents, journals, articles, and organizational profiles in our database, making us the national largest repository of health information on racial and ethnic minorities within the United States. In this free database, is available to the public 24/7, and you have the links as well. Next slide, please. And we will make this presentation available to the public. Also, the Research Center, Knowledge Center, we push information out to the public that is easy to use and to understand. Often this information is used by journalists and reporters, so there is a vast source of information here as it pertains to minority populations in the U.S. Next slide, please. And this is just an image of how the data will show and what would you be able to see, and how also you're able to research information by topic specific, as you will see there, by viral hepatitis. Next slide, please. Information services. Here, the information specialists are available Monday through Friday from 9 a.m. to 5 p.m. You can call us and they will provide specific answers to your questions or directly to where you can find further information. Examples of information we can assist with include database research results, funding sources, and the most current data specific to a variety of health conditions and issues affecting racial and ethnic minorities. Information services is also the lead team for our participation at a variety of national and local conferences and meetings. Next slide, please. And with this, we conclude today's webinar. Once again, Dr. Alam, thank you so very much for taking time off your busy day and to be with us. Maria, who has been the technical assistant behind the scenes, thank you. And to the public, thank you for being with us. This webinar has been recorded and will be available to you. We will also make available the slides. Please do provide us with your feedback. The link will be also made available to you. Thank you.
Thank you. Thank you.